ما شاء الله بالله.
عبد الله can you call them نبدأ الحين. محمد كلمهم يا أخي. ببدأ يلا. كلمت دكتورة ليلى الجاسم تيجي. ريم الحين she's discussing which car she wants to buy. أقول أنت you're discussing what is the best car for females. بس لازم تشترين وردي بينك. يلا عبد الملك. عبد الملك كلم الشباب قول لهم تعالوا يلا بسرعة. والله Thank you, Doctora. Should we start? We have a big crowd here. We have a big crowd. يلا بسم الله. طيب السلام عليكم ورحمة الله وبركاته. أبو سارة, can you have a seat please? طيب بسم الله الرحمن الرحيم. My name is Hamoud Mohammed Al-Ataibi. I'm a third-year resident at King Khalid Eye Specialist Hospital program. We are going to talk about an article. The title is Comparison of the New Low-Cost Non-Valve Glaucoma Drainage Device with Ahmed Glaucoma Valve in Refractory Pediatric Patients in Indian Eyes, done by Dr. Senthil and her group. A little bit introduction before we discuss the article. We know that managing childhood glaucoma is challenging, and usually surgery is the mainstay treatment. In southern India, the prevalence of primary congenital glaucoma is high, 1 in 3,300, and here in Saudi Arabia, 1 in 2,500. The risk of failure is higher in children. So glaucoma surgery in children has higher risk of failure and greater complication rate compared with surgery in adult eyes. So the glaucoma drainage devices are indicated in these refractory cases who have failed filtering surgery or as a primary procedure in certain complicated secondary glaucomas. So what are the options in failed cases? The most common two devices that are used is Ahmed valve implant and non-flow restricted Barvelt implant. Because Barvelt implant is high cost and it's difficult to get in India and it's not available there, the lab called Orolab, they designed a new low-cost non-valve restricted device similar to Barvelt implant, known as the ADIS, or the Orolab aqueous drainage implant, that is available in India since 2014. This is a picture of the Ahmed implant. This is Barvelt implant, and this is the ADIS, similar to the Barvelt implant. The cost is around $145, the Barvelt implant, and the ADIS cost about $50 to $75. The reported success rate in Ahmed implant varies in different studies, ranging from 60 to 90% the first year and 30 to 50% the 5 years. Barvelt implant around 80 to 90% year and 50 to 70%, 60% at 5 years. The outcome comparison have been studied, but in very few studies between the flow restricted and the non-flow restricted, and there are no reports comparing the Ahmed implant with the ADIS, the newly available implant. So this study came out, the same title, comparison of the new low-cost, the Ahmed implant in refractory pediatric in India. The purpose was to compare the outcomes between these two devices in refractory glaucomas. The design is a retrospective interventional case series, and the participants is 128 eyes of 114 children. 12 eyes were excluded because of inadequate follow-up, and 5 eyes had ADs following failed Ahmed implant. So the total in ADs is 36 who met the eligibility criteria and 85 in Ahmed group. The methodology, as you mentioned, it's a retrospective review of the records of consecutive children aged from less than 16 years of age who underwent Ahmed implant or ADIS implantation from January 2007 to December 2016 with a minimum follow-up of 6 months. We'll be discussing the surgical procedures, the post-op regimen, the outcome measures, and statistical analysis. All procedures was done by a single surgeon, and the choice of the device was based on the diagnosis, severity of glaucoma, size of the eyeball, and time required or allowed for the IOP control. The cost of Ahmed implant costs about $350 US, and as we mentioned in the ADs, about $75 US. They mentioned specifically the surgical technique in each technique between the ADs and Ahmed implant, and there is a very important thing that we have to mention in any non-flow restricted is the ligation. They ligated with 2 ligators in all eyes with a 6O Vicryl. The post-op regimen, we know that it's antibiotics, steroids, cyclopentolate, and the follow-ups is day 1, week 1, week 3, and every month for 3 months, then every 3 months thereafter. B-scan was used to rule out any posterior pole pathology in all cases. So what are the outcomes you are looking for? Primary outcome is the IOP and the need for medication. The secondary outcome is the visual acuity, presence of hypertensive phase, and the post-operative complications. What is hypertensive phase? Anyone knows here? R1s? R3s? R4s, Dr. Hamid? Okay. So the hypertensive phase it was defined as IOP of more than 21 millimeter per mercury after the initial low or normal IOP with cystic and tense blip in the absence of tube block. This is the definition of the hypertensive phase. Then the statistical analysis. The results, as we mentioned earlier, that those who met the eligibility criteria are 116 eyes. 36 eyes underwent ADIS, the newly available in India, and the 85 underwent Ahmed implant. The results, we'll be discussing all these. The mean IOP at the last follow-up in the ADIS group was 12 millimeter per mercury, significantly lower compared to the Ahmed group. The medical management, medical therapy, demonstrating that IOP control without anti-glaucoma medication were significantly more in the ADIS group. The cumulative probability of qualified and complete success. What do we mean by complete success and qualified success? Dr. Zubair? R1, sir. Complete success means we did the surgery and no need for anti-glaucoma medication. Qualified success means we did the surgery and we need anti-glaucoma medication. Okay? So this is the meaning of qualified success. And both the cumulative probability of complete success, there is a mistake here. It should be complete success, was similar for both groups, which was 91 in the ADIS group and 88 in the Ahmed group. The rate of qualified success were low in both the groups, but significantly higher in the ADIS group. We'll be showing in this graph. So this is the complete success, means no need for anti-glaucoma medication. What was similar in both groups, the Ahmed and the ADIS group. But when we use anti-glaucoma medication, which we call the qualified success, the ADIS group have better outcome compared to the Ahmed valve. Okay, so the schedule demonstrating the demographics, the p-value is significant in the number of the other intraocular surgeries, which was 2 in the ADIS and 1 in the Ahmed valve. The follow-ups were less in the ADIS group because it was developed in 2014, so they have less follow-ups compared to the Ahmed valve, which was for 10 years, more than 10 years now. The post-op IOP were significant, better in the ADIS group compared to the Ahmed valve. The post-operative anti-glaucoma medications were higher in the Ahmed valve compared to the ADIS. And the number of eyes in hypertensive phase were more in the Ahmed valve. Okay. So the VA, in both groups, there is a decrease in VA after the drainage devices. No significance. The complications, clinically significant is the p-value here is the choroidal detachment, which was more in the ADs group because it's non-flow, and there will be risk of hypotony more than the others. And the delayed hypotony were more also in the ADs group compared to the Ahmed valve. So the critical appraisal of the study, you can find it in any website for those who are studied evidence-based medicine. So was the study question or objective was clearly stated? Yes. Was the study population clearly and fully described? Yes. Were the cases consecutive? Yes, it was. Were the subject comparable? Yes. The intervention was clearly described. They mentioned clearly the steps of each technique. Were the outcomes measures clearly defined, valid, reliable, and implemented consistently in all study participants? Yes. Was the length of follow-up adequate? Yes, but for me, I think 6 months is not that long duration to follow up the patient because there might be complication, might happen in a year or two. But compared to other studies, we can say yes. Were the statistical methods well described? Yes. Were the results well described? Yes. What are the limitations of the study? The limitations in any retrospective study, the non-randomization of the patients, the non-homogeneous groups in terms of implant size, the diagnosis, prior surgeries, and follow-ups. And because the ADs was available in the beginning of 2014. And the surgical technique, the same surgeon, we said that all cases was done by a single surgeon. And the same surgeon in 2007 is not the same surgeon in 2016. He will gain more experience. Right, Dr. Adi? Okay. So the conclusion, both ADs and Ahmed implants effectively lower the IOP in difficult glaucomas in pediatric patients with similar numbers of complications. However, better IOP control with lesser need for anti-glaucoma medication was achieved by using the ADs. Thank you. Questions? Yeah. Exactly. So the encapsulation usually will happen like in 2 years or something. But I compared it with other studies, which was like big studies in Ahmed valve, and they used 6 months as follow-up. I don't know, maybe Dr. here. And There is something, Doctora, because it's a new device. The conflict of interest, this study was published in India, and probably, I don't know, maybe there is like financial interest or something.
It's not financial, it's any surgical procedure
Yeah.
that we use first, okay? You will give the short term of this excess rate.
Yes.
To justify that it works the same. And then after that, we follow up with the patients, and we have seen it with one of the glaucoma devices that was withdrawn just now, because they have seen some complications after typing or being used, and we use it here and all around the world. I don't know how much the number, they said it's 10,000 or maybe I didn't remember, I'm not sure of the number. Yeah. So, and they would drop it after 5 years because they saw the complication. But any procedure that's new or device, they usually they recommend it at least 6 months of follow-up. But this is not a randomized study, so still we cannot decide if it is.
It's a case series.
Yeah, it should be blinded.
Yes. Two arm.
To arm randomized study, okay, so that we say it's good because there's historical bias, like you can pay the money for that because I know it's better, you don't have the money, I can do the cheaper version, or I want to try the cheaper version and see what's going on. So many factors, what was in the surgeon mind when he was to Ahmed that we need to decide the exercise. But the good thing that it's supposedly the same as barbell, but it's how much percentage of the price?
The price of the, which one, Doctora?
The AD compared to barbell?
The AD is like $50 US, and the barbell is like 150. It's like 3 times more than the.
Especially in high volume hospitals.
But here in Saudi, we get it in a higher price. This is in India, they have like special price. Here we have oil.
Yeah.
This is the reason. This is the reason.
Thank you.
Thank you so much, Doctora. Thank you. Any question? يعطيكم العافية. طيب, for those R1s, if you want to, can you please come forward? Thank you, guys. Thank you, Sarah Reem, for supporting me. Thank you, Zubair. Thank you, Dr. Laika. هلا عبد الرحمن. يقولون في شباب مسافرين رايحين البحرين. ايه في معتز وحاجزين اوريدي، فقلنا خلاص عشان كنسلت الرحله يقولون صح؟ نعوضك رحله ان شاء الله. المالديف على حساب عبد الله خان. ابو ساره تجي اللي بنبدا فيها اليوم عشانك انت بس. عبد الله can you join us please? You're still R2 خلاص. كلكم عبد الله. ها؟ في بعطيكم ان شاء الله. بالله كيف دخلت اوفتالمولوجي؟ لا ما يخاف، ارسل لك يعني. ترى ما كملتها انا، هي شوف قالوا كلموني الشباب قالوا انه ودنا انه تو بريزنت ات ايرلير. لا برسل لك على الواتس على ايميلك. ايش ايميلك دكتوره؟ waiting for the person to sign up. ظاهر لازم تسوين sign up اعتقد. if I'm not mistaken بس نشوف اذا اقدر اعطيك الكوبي. والله طيب. السلام عليكم ورحمة الله وبركاته. Good afternoon, everybody. My name is Mahmoud Mohammed Al-Ataibi. I'm a third-year resident, and thank you all for attending. Thank you, Dr. Abu Sarah. طيب, so we will be discussing the common ocular emergencies that we see here in KKESH. I will just give you like an approach. If there is any further like details, you can go and read about it. But it's really difficult to cover everything in like one lecture. So we'll be dividing it into 2 lectures. The first half we'll be discussing 3 things. We'll be discussing the anterior segment, the glaucoma, and the retina. Pediatric and oculo will be discussing it later, okay? طيب, in anterior segment, what are the things that you think common? Anyone? CD, okay, ايش كمان؟ excellent, ايش كمان؟ ممتاز، بس ما هي ER، تكامل ER. Okay, excellent. بالملك. برافو. عبد الرحمن. اي خلاص. بس هذه هي. Excellent. برافو. اوه تغششون. طيب ما في مشكلة. So we'll be discussing CD, MK, excellent, open globe, chemical burn, graft rejection, and high FEMA. So in the CD, make your life easy. Just put Pinox or the anesthesia drops and rule out open globe, infiltrate, and foreign body. Okay. Usually the CD will heal in a few days. Ask the patient if he's like wearing contact lens. Was there any trauma? What? Take good history. The trauma was by what? By finger, by vegetable material, by a fist, by a ball. You have to take full history from the patient, okay? And check if the epithelium is loose or not. If it's loose, you have to do debridement, remove it. And if it looks like this, you have to, what are the things in your mind? Anyone? Hervis, what else? Healing CD. ممكن healing CD, it can be like this. One of the differentials of this one, don't panic. One of the differentials, it could be healing CD. It looks like dendritic ulcer. But before you put anesthesia, if you see this and you're suspecting it, use like a Q-tip. See if there is like hypoesthesia, so you will suspect more the herpetic. Okay. Oops. When to batch, when not to batch. ممتاز. Excellent. And what else? Excellent. The finger. Trauma by finger, trauma by vegetable material. Do not patch. Okay? Just leave it like this. Okay? Otherwise you can patch. طيب, next topic is the MK, microbial keratitis. What are the locations we can find the MK or the infiltrate? It could be peripheral, it could be central, it could be anywhere, or paracentral. It's very important to mention the location. In terms central, paracentral, peripheral, and the size, how many. If it's 1 millimeter or peripheral, you don't have to scrape. Okay? If it's central or paracentral, you have to do scraping. And make sure, sometimes you see, oh, doctor, this is an infiltrate. It happens. لكنها سكار. كيف أفرق بينهم؟ Excellent. فيو do slit. بالميكروسكوب you do like a slit. شوف إذا في والله إديمة وفي CED on top of it وفي AC reaction وpain خلاص this is MK. طيب إيش ممكن يصير هنا؟ Can anyone describe? ممتاز ممتاز تكمل. برافو. What else? Excellent. Hypopia. طيب if you see this what you will do? Melting قال لك. فممكن if you do scraping you have to do scraping but you have to be gentle. طيب with scraping you have to do B scan to rule out endophthalmitis. صح ولا لا? It could be MK related endophthalmitis. do B scan but ask the technician to do it gently. طيب طبعا the location is important. ليش؟ طبعا هذه what do we suspect if we see a peripheral? Bravo, excellent. So this could be marginal keratitis. It could be due to blepharitis, due to systemic diseases. ممكن يكون واحد عنده immune related issues. صح? So you have to ask about the history from the patient and check if there is blepharitis or لا. What will be the diagnosis if there is blepharitis? اسمع كده تعرف. طيب. Peripheral infiltrate. أفا. طيب. Marginal keratitis, one of the differential, صح? طيب. We have to do scraping, and if it's, as we said, the medications that we can use is what? Vigamox or fortified antibiotic. إيش الfortified that you know? بس ما نستخدمها هنا في كيكش. هنا اللي في كيكش. Excellent, bravo. طبعا alternating. طبعا الopen globe. What do you see here, guys? Anyone describe? واحد بس يرفع يده. من؟ هذا. Iris prolapse, excellent. إيش كمان؟ إيش فيها البيوبل؟ إيش يسمون هذه؟ Peaked pupil. Peaked pupil. Iris prolapse و large wound. طبعا you have to specify الwound كم ملي مثلا. طيب. هنا وش تشوفون؟ Saddle test positive, there is a leak. What is this? Excellent. So this is self-sealed, full thickness laceration. This one, iris prolapse, not the same as this one. Okay. طبعا in open globe, you have to check the VA. How to check the VA? Excellent. إيش كمان? If they cannot see, light. طيب. use LP, NLP, hand motion, finger, counting finger. طيب. And complete eye examination. Look for full thickness, as we mentioned, scleral or corneal laceration. If there is severe conj hemorrhage that is 360 or bullous, you have to suspect open globe. If the AC is deep in this eye, or shallow compared to the other eye, we have to suspect in the كان في open globe أو لا. Peaked أو irregular pupil, lens material أو vitreous موجودة في ال AC. Foreign body tract. تشوف مثلا والله غصن شجرة أو cortical cataract مثلا عفوا sectoral cataract. جزء من lenses cataractus. So you suspect in trauma or foreign body went inside. تمام. And the intraocular content may be outside the globe. The limitation of the extraocular motility, which is greatest على the direction of the rupture. You have to be gentle مع examination. If there is nothing and you think, well, there is no open globe, dilate, check the fundus, look for choroidal rupture, retinal breaks, commissuratiny, or vitreous hemorrhage. Okay. Do not manipulate a lot. If you are sure about your diagnosis, this is an open globe. Check with the fluorescein if it's leaking or self-sealed. Ask the patient when was the last meal to keep him MBO. Okay, and the need for intravitreal antibiotic. And if there is like foreign body, مثلا trauma or pullet or something, you have to do imaging to rule out intraocular foreign body. Graft rejection, chemical burn. What are the chemical burn that you know about? إيش اللي ممكن يصير يعني؟ acidic, alkaline. إيش اللي more dangerous? Excellent. يصير في penetration more الكورنيا. تمام. طيب إيش classification that we know in chemical burn؟ ممتاز. So أنت شيء من عندك أنت. لا زعل. طيب عندنا two classifications. عندنا Roper Hall classification و Dua classification that we use mostly اللي هو this one it's much easier. طيب. If there is no limbal ischemia or there is CED and you can see the iris clearly, طيب, this is a good prognosis. If there is less than third limbal ischemia and you could see the iris, but with some corneal haziness, it's good prognosis. Limbal ischemia with total CED, well, iris details sometimes obscured. This is guarded prognosis. Yes. تشوف whitening زي هذه. شفت هذه كيف؟ This is limbal ischemia. If this is like less than a half or 1/3 تقريبا. This is good. This is grade 2. طبعا هذه قبل هذه بعد التريتمنت. طيب. فإذا كان grade 4 more than 1/2 limbal ischemia كون تكون كلها opaque. No, you cannot see the iris and you cannot see the details. This is poor prognosis. What you should do في الER? Irrigation. And the standard treatment is antibiotics, cyclobentalate, and steroids. Okay? طبعا what something we missed. إيش ممكن نسوي إحنا as physicians في الER? pH. Excellent. وش كمان؟ evert the lid. Excellent. ليش؟ ممكن في debris ممكن في باقي مثلا إيش الالكلاين that you know؟ في الكلاين في بالكم؟ اسمنت مثلا. Cement, you have to remove it. You have to remove if there is any debris في lids, you have to remove it, okay? And do irrigation again. طيب, graft rejection. Here in KKESH, because we do a lot of PKBs, you find a lot of patients with graft, sometimes suture removal. You call I have foreign body. Then you find out والله عنده graft rejection. طيب, how to know إنه في graft rejection أو لا? في signs. طبعا signs هذه مرتبة from the most to the least common. The most common is corneal edema, KBs on the corneal graft. ما هي على الريسبنت area فقط على الجرافت نفسها. Corneal vascularization, stromal infiltrates, chodedost line. What is chodedost line? Endothelial, excellent. Endothelial line. طبعا هو that separates the immunologically damaged endothelium from the unaffected endothelium. الاريا اللي damaged حيكون endothelium decompensated resulting in stromal and epithelial edema. طبعا متى سمي؟ الكبي ما تصير عندهم كثير. ايه لان ايه بالضبط هذا في البي كي بيز. طيب loose suture it's a sign of rejection. Yeah, risk for rejection, but you have to remove it. طيب the diagnosis of graft failure متى؟ تمام. You treat the patient for 2 months still the signs is there. You label the patient as graft failure, not rejection. طيب. Excellent. طيب. The second thing is the hyphema. It could be total hyphema. What do you call this? 8 ball. Or it could be like 3 millimeter hyphema. You have to ask the patient what was the trauma by. They can't by fist, by anything. You have. This is very important. Why? To rule out open globe. This is the most important thing. طيب سم. هذه. They call it 8 ball. شفت البلياردو؟ البلاك one. This is the. أيوه. Total hyphen. تمام. You have to ask about the age, sickler أو لا. And check the IUP. It's very important in the management. And document the height and the clot. Why we ask about sickle cell? لا. من اللي قال؟ ممتاز. Why? وش medications? Excellent. Acetazolamide. Carbonic anhydrase inhibitors. طيب. فإذا جاني patient I have to give him Brid 40, cyclobentalate, clear eye shield. If there is high IUB, we treat with anti-glaucoma medication. We have to make sure there is no contraindication in the medication that we give. When do we intervene? طبعا in 5% of the cases, 95% medical treatment of hyphema. يعني you give him the treatment هذه, Brid 40, cyclobentalate, clear eye shield, وبد rest, قل له ارتاح. لكن متى you intervene? In 5% of the cases. إيش اللي ممكن يصير؟ إيش الانديكيشن؟ 3 أشياء. Excellent. Uncontrolled glaucoma or high IUB. Second thing, blood staining على الكورنيا. You have to intervene. The third thing, resistance or large total hyphema. يعني أنت you measured him today 1 millimeter. In 2 days still 1 millimeter or more, or there is clot that did not يعني resolved. You have to evacuate. طيب. السيكل سيل ايش اللي ممكن يصير في السيكلرز؟ لما نعطيهم اسيتازولاميد الدايموكس مثلا، دايموكس عن طريق الفم ننزل الضغط، ايش اللي ممكن يصير عندهم؟ ايش السايد افكت في الدايموكس اللي وي دونت وانت في السيكلرز؟ برافو. فميتابوليك اسيدوسس حتسوي سيكلينج، يعني الار بي سيز ريد بلاد سيلز حتصير، فاهم علي؟ فالميتابوليك اسيدوسس اذا تزاد في الدم حيزيد السيكلينج، فهذا اللي ما نبغاه. This is the contraindication in sicklers. That's why it's important to ask if the patient is sickler أو لا. طيب any questions so far؟ طبعا هذه الموست common، ما في أشياء كثيرة ما غطيتها. any questions؟ في سؤال في بالكم؟ طيب الجلوكوما، common cases in glaucoma that we see in the ER is high IOP. It could be caused by open angle, closed angle, whatever. صح؟ ايش اللي ممكن how to measure ال IOP by what؟ golden. We have to master it. ان شاء الله في future lectures حيكون في practical session ان شاء الله how to check ال IOP، حتطبقون على بعض. اللي ما يحب الثاني امزح. زبير معنا ان شاء الله، زين؟ ترى مو بس كيكش. الله يحييك. وين دكتور ابو ياسر بعد؟ ابو ساره، ابو ياسر. طيب فتشيك الاي او بي باي جولدمان، تمام؟ and start stat anti-glaucoma. ايش قلنا يا شباب؟ make sure there is no contraindication. Sicklers don't give Diamox, don't give dorzolamide, topical dorzolamide, anything that might cause sickling, avoid it. طيب ما عنده سيكل، سهل. برافو. أزمة ما تعطي ايش؟ بيتا بلوكرز. اكسلنت. ايش كمان؟ برافو. ليش رينال فيلر دكتورة؟ برافو. excellent. ask about any systemic diseases. Ask about excellent. You give what? Iopidine. You give iopidine. Yeah. طيب always consult glaucoma team. Otherwise طبعا second بعدين second، تعرفون عسكرية هنا. ايوه بدين اعتقد، بس اذا عمر معين ظهر above 6 اتوقع. I forgot في study عليها. لكن we don't give الفاجان is contraindicated في البيدياتريك. This is يعني ممكن حتى في common MCQs تجي. والله ناسي. لا البيدياتريك الى عمر 6 سنوات اعتقد. سوى في دكتور سامي الشهوان سوى study عليها بس ناسي والله. ممكن if you search الفاجان دكتور سامي الشهوان ممكن صح. I forgot والله ناسي. always consult الجلوكوما تيم. ذكرتني ايام الميديكال سكول بالايباد غش. طيب امزح. طيب ايش السكند موست كومن؟ بليبايتس. طيب we have a lot of glaucoma cases that underwent filtering surgery زي trab, deep sclerectomy, and always any glaucoma patient make it happen. Invert the upper lid, ask the patient to look down, look at the blip. هل هو well formed, في leak, cystic, anything. تمام؟ Very important. Or what is this sign? What do you call it? معتز لا تغش. تفضلي دكتورة ديما. حياكي. ورطناك يا. What do you see here? ها؟ This is white on red appearance. لما تيجي تقول والله there is severe conjunctival injection, there is white on red appearance, there is what looks like pus, تمام؟ and there is what? Hypopyon, تمام؟ طبعا الجريدنج of blepitis. Anyone read about blepitis? طيب blepitis عندنا 3 grades. grade 1 يكون فقط ايش دكتورة ديما؟ excellent. برافو. grade 2 AC reaction. Excellent. يعني blepitis plus AC reaction. grade 3 excellent. فيسمونها ايش؟ blip related endophthalmitis. grade 3 يكون endophthalmitis. ابعد لكم اياها. I will repeat again. So عندنا 3 grades للبليبايتس. grade 1 حيكون بس blepitis localized على الاريا هذه، ما في هايبوبين، ما في AC reaction. grade 1. grade 2 حيكون في AC reaction، حيكون في هايبوبين، حيكون في. إذا صار المشكلة كذا grade 2 كيف بعرف أن إذا عنده endophthalmitis أو لا؟ I have to dilate him, this patient. I label this patient as blebitis to rule out endophthalmitis. So the diagnosis in grade 2 is blebitis to rule out endophthalmitis. ليش؟ لأنه I have to dilate the fundus, check if there is vitritis involvement, هل في retinitis, طيب, vasculitis, very important. Do B scan. If you see hypopin, AC reaction, and you suspect this is endophthalmitis, طبعا endophthalmitis is a clinical diagnosis. B scan will support your diagnosis. تمام؟ طبعا وcheck for the leak. في سؤال؟ لا ما ادري ممكن بس لحد علمي انه هي ستيبس. تمام؟ تمشي انه بليبايتس بعدين تدخل على جوا الاي سي ومن الاكويس على الفيتريوس بعدين تروح للريتنا وبعدين اندوفثالمايتس. كلير؟ واضح الجريدز؟ ترى this is common question يعني ممكن يجي بس انت هذا for your own benefit انكم تحطوا في بالكم انه ايش التريتمنت. You admit the patient, you call. طبعا you have to rule out في الحالة هذه في الجريد 2 you have to rule out endophthalmitis, call retina if there is endophthalmitis. If there is no endophthalmitis check طبعا الاي بي وcall glaucoma. Tell them انه there is blebitis for admission هذه. ايه blebitis you have بدون AC reaction. You have sometimes بعض الكونسلتنت يقول لك لا give him Vigamox Q hourly وبعدين give follow up ER. طبعا تختلف من استشاري الآخر. طيب لكن البيشنت ما راح he will be in severe pain ترى. If you see patient with blebitis he's in severe pain. فصعب انه بيحط قطر نفسه لازم you have to admit him. ايش الثيرد most common؟ What is NVG؟ طبعا we did دكتور بروف العبيدان he mentioned the study. he presented I guess 2 weeks ago. what is NVG and what are the grades that he mentioned? Anyone knows? تفضل دكتور معتز. برافو برافو. من غششك هذه؟ أنا فرنكول. إيه طيب. this is the grades. Anyone can repeat what Dr. Matez said? جبرين. grade 1 إيش قال؟ كل الجريدز NVI و NVA. تمام؟ خلونا نتفق خلاص. عندنا في ال MVG 3 grades. تمام؟ كلهم نيو فاسكولاريزيشن على الايرس ونيو فاسكولاريزيشن على ايش؟ على الانجل. كلير؟ متفقين؟ طيب جريد 1 ايش فيها؟ الانجل از كذا اوبن فيري اوبن. الاي بي نورمال. واضح؟ هذه جريد 1 نورمال اي بي انجل از اوبن. طيب جريد 2 نورمال يعني اوبن انجل ولكن الاي بي از هاي. هذه جريد 2. جريد 3 كلوزد انجل. ليش صارت كلوزد؟ مع الوقت حيصير في فايبرس ومع نيو فاسكولايزيشن وليك وبلد تطلع وفايبرس فتصير مع الوقت حتصير ايش؟ كلوزد. طيب واضحه الفكره؟ سهله. طيب ايش الكوزز اوف ام في جي؟ ايش اسكيميا؟ برافو متفقين انها اسكيميا. What are the 3 most common causes of ischemia؟ تيومرز. ايش من جدك معتز؟ اتق الله يا اخي استهدي بالله يا راجل. لا ايوه اللي هي ايش؟ ocular ischemic syndrome اللي لازم يهاف تو تشيك الكاروتيد كارديك ستاتس. واضح عبد الرحمن؟ طيب فثلاث اشياء ايش؟ قلها. CRBO ocular ischemic syndrome لا central retinal vein occlusion غير. ocular ischemic syndrome يكون عادة من causes R3 الكاروتيد artery occluded فتسبب لك. طيب طبعا in these cases you have to check إذا patient is not diabetic not hypertensive no. طبعا 2/3 من الكيسز of MVG studies 2/3 caused by these two. سنتين هذه. الأذر ثيرد ممكن تكون تيومر زي ما قال معتز. ممكن تكون sickle cell patient with sickler. طيب you have to check the visual acuity. دكتور شو اسمك؟ صالح. Why we check the visual acuity? It's very important في ال approach صح في المانجمنت. إذا ال patient is blind what you will do دكتور؟ برافو. There is different. Excellent. Excellent. يا برافو عليك. excellent. فإذا كان زي ما قال الدكتور إذا كان عندنا no light perception ما يشوف البيشنت what you will do إذا pain you treat him as blind painful eye. If he's not in pain observe. واضح هذا بالنسبة للفيجوال اكويتي. إذا قلنا إذا قسمناه قسمين seeing not seeing. if he's not seeing treat him according to pain إذا pain ولا لا. If he's seeing visual acuity طبعا فيه على حسب إذا كان الIOP normal ولا لا. الIOP if it's high you have to treat the IOP medically. الميديا كلاريتي هل في كاتاراكت ولا كلير ميديا؟ ليش يهمنا الميديا كلاريتي؟ ليش دكتور عبد العزيز؟ طبعا الوحش الER جاء. Why we have to have good media that is clear في الMVG. Excellent. طيب the reason why we have إذا patient ما عنده كاتاراكت وكلير ميديا he's يعني good for BRB. لكن إذا كان ما فيه media it's not clear في كاتاراكت we have to inject. BRB it will be difficult otherwise we'll hit the macula. طيب and what is the second treatment إذا كان IOP high media is clear we did BRB we did intravitreal injection surgery. What is the surgery? Trap. Excellent. Trap failed اللي هو implant. في refractory cases قبل شوي تكلمنا عنها. في refractory cases إذا سوينا trap أو سوينا DS deep sclerectomy failed we go for tube أحمد valve ولا Barvelt ولا ADs ولا whatever. Always consult عبد العزيز الشمراني. And retina and glaucoma. طيب clear الجلوكوما هذه ترى 3 common cases. ما ادري اذا في دكتوره ديما في شيء زياده جلوكوما ما في اتوقع صح. هذه الموست كومن. طيب دكتور عبد العزيز في شيء في الجلوكوما تضيفه؟ طبعا في 3 اشياء وديسكس قلنا هاي اي بي بشكل عام اي حاجه. الشيء الثالث اللي هو الان في جي والبليبايتس. تمام كلير. طبعا الريتنا it's a big topic صراحة والفيايتس لكن هذه I picked the most common that we see في الER. Anterior uveitis, traumatic iritis, endophthalmitis, RD, artery and vein occlusion. Anterior uveitis always you have طبعا في حيكون في practical session إن شاء الله. دكتور عبد العزيز الشمراني he will be إن شاء الله giving a practical session and how to use a slit lamp, how to check the IOP. And also he will give about drugs صح؟ طيب AC reaction you have to check ال AC reaction. كيف how to check دكتور عبد الملك ال AC reaction؟ excellent. فتكون 45 degrees 1 by 1 millimeter. طيب high beam high intensity beam. excellent. فتشوف you look for AC reactions. تعرفون كم how to grade it plus 1 plus 2 plus 3 أسمع. طيب عبد الملك trace. طيب 5 to 15 plus 1 15 to 30 plus 2 ها 25 yes. وليد شكرا. وليد كمل. excellent. يعطيك العافية أبو خالد. It's very important to know the sun classification. طبعا very important to know اللي هو ايش انه we divide the uveitis into 3 things anterior intermediate و posterior uveitis في pan uveitis لكن احنا we'll discuss anterior uveitis لانه هذه the most common that we see. طبعا commonly تكون unilateral. طيب what you can see في unilateral what is this ciliary injection دكتور what is this هذه ايش هذه إيش؟ Come on guys. لا لا بستير سينيك. إيه أوه صح إيه اللي هي صحيح ما أعرف اسمها ترى والله شوف R3 الحين. ف this is injection. طيب this is what mountain fat KBs. Excellent. For these you have to suspect in patient with uveitis, okay? And always consult uveitis team and your second on call of course. What you see here هذه كم تقريبا ACE reaction دكتور عبد الملك؟ You have to count it. حبة حبة بالضبط. تقريبا +3. فالتروماتيك ايرايتس لما if you put cyclopentolate it will be not fully dilated تكون mid dilated. طيب what is the treatment of traumatic iritis? Cyclo and Express 40 tapering. طيب follow up. طيب الendophthalmitis as we mentioned earlier you know it's a clinical diagnosis. When to suspect endophthalmitis? What are the signs we are looking for? Okay, excellent. Take full history. Post-op ممكن not post-op. إيش؟ Trauma. Okay, excellent. إيش كمان؟ دكتور وليد. History بعدين examination. طيب examination. What are the signs you are going to look for? Okay, excellent. Excellent. طبعا اللي قبلها طيب before الآي lid edema. طيب look at the lids if there is lid edema, if there is conjunctival injection, if there is red reflex as mentioned by Dr. Walid. Do full examination and look at dilate the patient and look at the fundus. You're looking for what, Dr. Abdulaziz? Yeah. طب لا تصرف. Excellent. زي هنا. صح. Not typical. تلقى endophthalmitis burning. صح. درين صح. excellent. excellent بالعكس. it's a full picture صراحة. صح. blip related. صح. طيب ايه طبعا yeah. ارفع صوتك دكتور بس. أنا سويت study صراحة. أنا I'm doing study here in KKESH و I noticed إنه ال most common signs اللي موجودة reported في KKESH اللي هو lid edema وال conjunctival injection أو chemosis عفوا والpain. ثلاث أشياء هذه three most common signs reported in patient endophthalmitis اللي في KKESH but not published yet under publication. طيب فيه لا محمد رسول الله. طبعا could be MK related, could be after cataract surgery, it could be blip related. It's very important in these patients to rule out endophthalmitis. You have to call Abdulaziz first, then retina, okay? And intravitreal antibiotic. They might be using a fortified antibiotic and systemic antibiotic in some cases. الRD طبعا في الريتنال ديتاتشمنت هذه طبعا one of the common cases that we face here in ER. What are the RDs that you know? Excellent. ممتاز. طيب ايش يهمنا في الRD؟ patient جاك في الER الساعة 2 الفجر، عبد العزيز نايم. What you will do عبد الرحمن؟ ما تفرق انت you are examination جاك واحد RD. What you will do؟ Excellent. بعدين do full fundus examination وش including what 90 20 ما شفت البريك use what ديما quadrispheric. excellent. quadrispheric. طيب to give you better field you can control the patient خاصة بعض البيشنت شوي difficult. localize ال RD where is it superior inferior طبعا everything is reversed في اللينس. and the macula status هل الماكلة is on ولا والله الماكلة تشوفها طالعة ماكلة off وإذا if it's يعني ها almost الماكلة is هل الفوفيا on ولا لا؟ ممكن part of the macula is off لكن الفوفيا is still on. طيب it's very important to mention these four. طبعا Lenkov's rule you have to know it. It's long. I didn't want to spend time to talk about it لكن it gives you مثلا إذا كان البريك هنا الأرضي إذا كان الأرضي مثلا بولس البريك ممكن يكون هنا فهمت قصدي you have to memorize it. This is regarding الأرضي. في ال retinal vein occlusion what do you think here? What is this دكتور زبير؟ لا وينها؟ cherry red spot هذه ها؟ هذه what؟ أي ممتاز branch retinal vein occlusion. طبعا وش نسمي الساين هذه عبد العزيز؟ نبدا بالسينيورز عشان ما ها؟ عبد العزيز شمراني والله. طيب وليد وعبد الرحمن يلا عبد الرحمن ها؟ ايفون ايش؟ ثاندر ستورم. ثاندر ستورم اوكي. طيب ساين اوف وات؟ سنترال ريتينال فين. فهذه البكتشر حق سنترال ريتينال فين. diabetes hypertension, diabetes. If it's bilateral, you have to do full workup. والage طبعا important. إذا كان في السي ار في او والله الايج عادة متى يكون الايج؟ ها؟ old في الفيفتيز وابove. إذا والله جاني واحد عمره طيب الايج is important. طبعا واحد جاني والله عمره 20 سنة وعنده نفس البكتشر هذه. What you will do? You have to work him up, know what's the diagnosis. There is something should be there. إذا والله diabetic أوكي ممكن، لكن عادة الدايابيتك ممكن type 1 diabetes. طيب فالدايابيتكس they might إيش الكوزز ممكن في السي ار في او؟ diabetes, hypertension، إيش كمان؟ أوكي excellent. زي excellent وإيش كمان؟ في شيء ثاني. OCP oral contraceptives. طيب في الفيميلز تسأل هل تاخذين oral contraceptive أو لا؟ very important. طيب malignancies ممكن happen تسبب لك hypercoagulability status زي ما تفضلوا الشباب. زحمة. طيب نكمل لذيذ. طيب what is this يا زبير أكيد عارفها. إيش هذه؟ excellent. It comes with what؟ طيب patient جاك ونفس البكشر هذه central artery occlusion. What you will do؟ أنت في الإيار first on call. I'm depending on you. I'm sleeping. ها؟ برافو. ممتاز. لا مش باقي. في حاجة. excellent. كيف؟ لا في شيء. ايش كمان؟ تعطيه دايموكس، تعطيه كذا، وايش كمان؟ باراسينثيسيس. Very important. طبعا I had one case in my life last year. نفس هذه CRAO lady one-eyed. She came light perception. طيب we examined her. طبعا كانت few hours طبعا خلال ساعتين central artery occlusion. the same picture exactly. So we did paracentesis, we decreased it, we did ocular massaging. Vision from light perception to 20/100. Alhamdulillah, يعني we could save some part of vision. مع الفولو ups we consulted the retina طبعا. I saw her by accident in one of the ER on calls. Vision was 2200 last time I saw her. فسبحان الله, it's very important. So this is sight saving. You have to know it. If you don't know it, you have to read about it. You are obligated to know all these information. رجاء. We are depending on you عشان أنا وعبد العزيز النام. زين بكرة بتصيرون سينيورز عشان ترتاحون يعني. هذه إيش؟ branch retinal artery occlusion. طيب من اللي أمه دعيت له؟ دقيقة. هذا ولا هذا؟ إيه. هذا أمه دعيت له؟ داعي عليه. وهذا؟ ليش؟ وش another branch؟ excellent. another branch. طيب هنا السيلولر ريتنا spared. فهنا كل الارتري is occluded. هنا هذا أمه داعية له تحبه. وهذه شكله مسوي مصيبة. طيب anyways هذه next time إن شاء الله بنكمل لكم عاد الأوكيوبلاستي والنيوروفثالمولوجي وبيديا. الشباب اللي حجزوا تذاكر المالديف enjoy your moment. ترى قدمناها عشانكم، أنا ما كملت المحاضرة for you only، بس عشان ما باقي لنا أوكيوبلاستي ونيورو إن شاء الله. متى تبغون المحاضرة إن شاء الله والبيديا؟ متى يناسبكم؟ بس ما تحجزون بعدين تقولون والله معليش والله عندنا سفرة، ألغت الدكتورة هند قطان المحاضرة نبي نسافر. ها؟ ثلاثاء بعد الظهر بعد الجراوند راوند، ايش رايك؟ بعد الجراوند راوند الأسبوع القادم. لا نكول معليش، بدلت نكول عشانكم، بس ما في مشكلة. نخليها متى؟ شوف السبت كويس. لا امزح. عاد نسقوا بينكم، اهم شيء ما يكون وقت كولي عشان زين. بس كلمني عبد الملك زين. اتمنى انكم استفدتوا، وترى ما غطيت اشياء كثيره. وشكرا عبد العزيز عبد العزيز ووليد جزاهم الله خير. Thank you very much and sorry I did not finish my presentation, I apologize. وان شاء الله see you next part. طبعا في practical part وفي اشياء ثانيه you have to attend. الشباب اللي من برا كيكش you are most welcome. الله يحييكم أي وقت تنورونا، بس الزيارة الجاية بفلوس ب10 ريال بعد الضريبة 15. يلا مع السلامة.